I'm Dr. David Pitches, a consultant in public health, working for Dudley Council, and for the last few years supporting Dudley CCG in the development of the MCP, or multi-specialty community provider. As a doctor, I'm passionate about improving health of entire populations rather than just the health of an individual person. And indeed, I would see my patient as being the population that I'm responsible for rather than just the patient in front of me in the waiting room. Now, in the case of Dudley's MCP, the first involvement we had in public health was perhaps looking at some of the outcome indicators and giving consideration to how we could embed prevention into every clinical pathway and into the outcomes framework. In a period of time where there are funding pressures, it's particularly important not to lose sight of prevention, and the MCP is a great delivery means of ensuring that that prevention can be written into the indicators, can be written into the outcomes framework, and can be part of the everyday currency of clinicians' language, so that we can optimise healthy behaviours, and support those most effectively who already have long-term conditions by helping them to manage those conditions more effectively. Developing the MCP model, it's clear that a number of public health services, including sexual health, NHS health checks, school visiting, and adult wellness, which includes weight management, exercise and smoking, to name but a few services, will be transferring into the MCP. There's a clear rationale for this. These are preventative services which have a big and fairly immediate impact on the NHS. And it's in the interests of the health service to invest in prevention, particularly in these areas. And so with our CCG colleagues, we've been actively involved in scoping and identifying the clinical pathways and ensuring as seamless a mechanism as possible between prevention and management of clinical disease. To take the example of health checks, this is a programme for patients aged between 40 and 75 who don't already have pre-existing conditions such as heart disease, but who may have risk factors for cardiovascular disease and also for cancer, diabetes, dementia and other long-term conditions. By screening as many patients as possible in Dudley over the last few years, not only has this enabled us to identify people with modifiable risk factors who are then able to be referred into our lifestyle services, which are going to be delivered through the MCP. It also enables us to be better informed of where patients who have got modifiable risk factors may not be choosing at this point to address them, and it gives us a much better understanding of the health needs and the current health status of our population, which will be vital in going forwards and making best use of our resources to support those who are at risk of developing long-term conditions. By embedding prevention in all pathways, by promoting and making every contact counts, by making Dudley's health service a place that's healthy for staff, clinicians and non-clinicians to work in, by embedding prevention in all pathways, the MCP has a potential to be a very powerful vehicle for embedding anything from community development through to improved prevention and management of long-term conditions. In thinking about the opportunities that this provides for other areas who might be looking at similar new models of care, the advice that I could give is to say that one of the things that frustrates me most as a doctor is when I hear clinical colleagues complaining about something as not being in their patient's best interests. The language here in Dudley is completely different. What I find so stimulating is when I hear colleagues, clinical and non-clinical, saying that something is in the best interests of the community. They're looking at not just the patient in front of them, they're looking at all the patients and how the whole community can benefit from this. When I'm sitting in meetings, listening to people talking about partnerships and relationships, when I hear clinicians talking about what we can do to improve the resilience of the population and help people to live more healthily and to help support those with long-term conditions, to manage those conditions more effectively and to be more empowered, I feel that my job as a public health doctor has pretty much been done, and the clinicians who are leading this from the CCG are the ones who are taking it forward to new places.